But we're in for a treat for our next speaker. He's an assistant professor of medicine, interventional and critical care cardiologist. He's from the University of Minnesota Medical Center. He's a president of the Minnesota Mobile Resuscitation Consortium. He will be with us presenting the mobile ECMO for treatment of out-of-hospital refractory ventricular fibrillation. Please join with me in welcoming Dr. Jason Bartos.
Thank you very much for the invitation. It's great to be down here. And just a couple disclosures. First, I'm not a surgeon, so this is still a safe space. We can still talk about surgeons. And the second is that I'm an interventional cardiologist and a critical care cardiologist, but I'm going to be talking about ECMO. And it's obviously a growing field of use of the technology you folks use every day. From what I just heard, a much simpler version of what you use every day. And a sort of perfusion for dummies, which is about what I need. It also is a growing use case in the world of interventional cardiology and cardiogenic shock. And so as much as I think to this day, am a little unusual being an interventional cardiologist, in many of your institutions, the cardiac surgeons or surgeons in general may run your ECMO programs. It's a growing device for us, and you're going to see more and more interventional cardiologists intersecting with you in this field. So I have some disclosures that are all just federal funding and some philanthropic funding for the program, our ECMO program, our mobile ECMO program, and our hospital-based program, and some research associated with it. So I know you guys don't spend your days thinking about cardiac arrest. That's what I spend my day thinking about. Cardiac arrest is obviously what you guys induce to some extent, though a very different scenario, obviously. For us, we're treating people, especially when we're talking about out-of-hospital cardiac arrest, who are in a very uncontrolled setting with people who have no expertise or can provide no help. And obviously, it's a shock. It's a surprise. It's something they were not planning or even see coming. And in most of our patients, they had no symptoms before their cardiac arrest. They were simply walking around, shoveling in Minnesota, shoveling a lot of snow, mowing lawns, playing golf, doing things outside with their families and kids. And then they go down and their family has to respond to that. And so really the entire chain of survival is important for these people as we think about it, recognition of the cardiac arrest, activation, 911, et cetera, all the way through to the discharge planning and post-discharge care. But when we think about just cardiac arrest itself, there are really three barriers to survival that are the prominent barriers. The first is getting return of spontaneous circulation. So obviously CPR is critical. Everybody needs to learn CPR and be able to do good bystander CPR. Chest compression only is great for their, as a bystander for their loved ones or their neighbors. But in many people, you cannot achieve return of spontaneous circulation even with the best of CPR. And so that's really one of the biggest hurdles for survival. The second is rearrest. Even after you get return of spontaneous circulation, about a third of people are going to rearrest sometime before they get to hospital admission. And so this is a big limiter to get people to the point where they can be admitted and have underlying etiologies of that cardiac arrest addressed. And then the third one, and the one that is still very nebulous for all of us at this point, is neurologic recovery. And this is a big issue that, again, many people are focusing their entire careers on, but we still don't have great tools to predict and or treat and improve neurologic recovery. So about 7-8 years ago now, we looked at our numbers in the state of Minnesota, and every one of your states soon, hopefully, will be able to show you this because the federal government passed a law recently funding the CARES registry, which is really a database for all cardiac arrests. Many states have had this for quite some time, but this is now going to become more of a national effort. And in Minnesota, we have had it for a while, so we had the benefits of that data. And when we looked at it again 8 years ago, we had about 7,500 cardiac arrests over the 5-year period, and about a third of them were shockable rhythms. And the reason I mention that is because in every category, people with shockable rhythms do better. The CPR quality is probably better. There's a lot of theory about why that would be, but CPR quality is probably better because you're replacing the heart and the VF is the cause. Therefore, it's a heart problem as opposed to severe hypotension from sepsis or hypoxia, these other causes of arrest. So shockable rhythms tend to do better. In addition, you have defibrillation delivered on scene, AEDs in every community, hopefully near you at a time when you encounter somebody with a cardiac arrest, and you can bring that to bear and get ROSC in the field much easier. For us in the state of Minnesota, only about a third of the cardiac arrests were shockable over those 5 years, and that's a pretty similar ratio to probably what you see in most of your states. And then the next step, if you follow that leftward chart and you follow the x-axis, it goes through the steps of a person's recovery and sort of care for cardiac arrest. So you have everybody on the left. The next step is ROSC, and what you'll notice is even in the shockable group where you have defibrillation, you have good CPR, about half of the people don't ever achieve ROSC. Of those people who achieve ROSC, about 2/3 leave the hospital. But overall, as a group, as a cohort of shockable rhythms, only about a third of the people left the hospital. And so what we said at that point was, what can we do for this half of people that never get ROSC? CPR is not enough. ACLS has failed. There's nothing else that can be done in the field. What can we do for them? In that case, in that time in the hospital that would help these people that don't get ROSC. The other component is the efficiency of CPR drops off over time. And so if you look at your patient population as you're doing CPR, in the first 15 minutes or so, you get about 80% of the people back who are going to get back with good neurologic function. You get those people back in the first 15 minutes. You get up to about 95% at 30 minutes. So after 30 minutes, doing ongoing CPR, you may get 5% of the eventual survivors back, but you almost get nobody back at that point. It's a very small number of people. So the efficiency of CPR, the ability to do good CPR at that point is starting to stop. There needs to be something else at that time point to do. And back again, 8 years ago, there really wasn't. So at that point, we started our ECPR program at the University of Minnesota Hospital. The ECPR is the use of ECMO for CPR. It can be done in many different settings, and we'll talk about basically all of those examples in this talk. The first, though, is to bring people to the hospital, transport them with ongoing CPR, with mechanical CPR in our case, to the hospital where we can deploy ECMO and basically provide them ROSC. Instead of requiring their own heart to do it, now we do it with the pump. And we started the Minnesota Resuscitation Consortium's program for ECPR, which really had 3 key priorities. So the first is early mobilization from the field. The second is to achieve that hemodynamic stability with the ECMO, and the third is to treat those underlying etiologies and causes of their arrest. Now, at this point, as is true in 99% of the nation, even today, the typical protocol for EMS in the setting of cardiac arrest is to work people on the scene for a half hour and then do one of 2 things: stop, declare them dead, or bring them to the hospital and have the emergency department declare them dead. That's the unfortunate protocol in most communities, unfortunately, even today in this country. ECPR, again, is the next step. And when we rolled this program out, it's a huge change in their practice, because instead of giving them 30 minutes on the scene, now we're saying you need to move within 10 or 15 minutes. Pull that person out of the 6th story of that apartment building, bring them down the stairs because there is no elevator, and get them into a truck and get them moving within 15 minutes. This is a big ask, and this requires a huge movement and change in plan in the EMS and pre-hospital setting. Our paramedics have been excellent and have really embraced this. It's very much more of a trauma mindset than anything now, but this is very different than what people do in any community at baseline with cardiac arrest. The rest of it was stuff we had control over: the hemodynamic support with ECMO, the treating the underlying etiologies. Of course, we use ECMO for this: 15 to 17 French arterial cannulas and 25 French venous cannulas placed in the femoral artery and vein. We place a distal perfusion cannula for everybody. And we use the CardioHelp system. For those of you who haven't seen it, maybe you all have. It's about the size of a bread box. It provides a lot of additional data which we can use to resuscitate these people in the moment. So we can get SVO2, hemoglobins, temperatures. These are all things that for cardiac arrest patients, they are often coming in at 34 degrees. These are people who are cooled by nature. And not even just because it's Minnesota. It's also in Minnesota. But they're also cooled by just the air, the ambient temperature, even in the summer. So that extra data is extremely helpful for us to try to resuscitate them and bring them back. And what the ECMO provides is really getting rid of the first 2 hurdles. So again, we mandate ROSC basically with a pump. We then get rid of the risk of rearrest. Even if they go back into VF, they can be in VF and they still have complete flow. And in fact, in most of these cases, or at least many of the cases, we don't have them out of VF until actually we've done the angiogram, the coronary angiogram, we've done the PCI to fix their underlying coronary disease. Now we can shock them out. That was the reason they were refractory in the first place, was that coronary occlusion. So now they can be in VF for another 30, 60 minutes after we get them on pump, and that's okay. They'll just stay in VF. This is us doing it in the cath lab. Again, the first setting we tried, we brought all the patients to us and had that controlled setting of the cath lab where we as interventional cardiologists were very, very comfortable. This was the protocol. We asked the paramedics to find us patients that were between the ages of 18 and 75 who had shockable presenting rhythms. They could be shocked into PA or asystole, but they had to start shockable. That includes an AED. So if bystanders brought an AED and it was shockable, it recommended a shock and they delivered that shock, that was an eligible patient for us no matter what the rhythm was when paramedics arrived. They had to be in refractory cardiac arrest. That meant 3 shocks if they were in VF that whole time, or they could be, again, shocked into PA or asystole, but they had to at least be refractory cardiac arrest. It couldn't be DNR, DNI, coming from a nursing home, etc. Once the paramedics identified those people, they called us as they were coming in. So field activation, our whole team would be ready when they arrived. And then when they got to us, our goal is door to ECMO time in 6 to 8 minutes. My fastest is 3. And so we bring them straight in, throw them on the cath lab table. Our nurses have to sort of relearn their process for patients coming in cath lab. There's no straightening of IVs or understanding what lines people have. We just pick them up with the help of firefighters or paramedics who are bringing them, plop them on our cath lab table, and go. We get access in the femoral artery or vein and send that initial blood gas off to our techs in the cath lab who can run it in the cath lab to get us 2 critical values, the PaO2 and the lactic acid. And we use those as cutoffs to guide who's eligible for therapy. About 15% of our people will not be eligible based on our cutoffs. And those 2 cutoffs are a PaO2 of 50 or higher and a lactic acid of 18 or less. So these are pretty liberal cutoffs. They're not incredibly exclusionary, but still about 15% of our people will not meet those because of something. The most typical issue is the PaO2. They aspirated, had a large aspiration event, they were never able to oxygenate them. And that's really what those criteria are meant to do, is sort of weed out people who had a failed resuscitation. These people on average have had CPR for an hour at that point. And so an hour of CPR with no oxygen getting in, we still believe is usually untenable and unsurvivable. Although we also have patients who have broken all of these rules. We have a person who was swimming at the Y. They have actual security camera footage of this person swimming at the Y, stood up in the pool, and then collapsed. So he arrested and then drowned. He was pulled out of the pool. They pulled him to the side. They did not dry him off. They were standing in a puddle. They slapped on the pad, started shocking him. You can watch this on the security camera footage as we did with a bit of a chuckle in retrospect. Shocked him 3 times, of course, nothing. They brought him to us. His PaO2 was 38. His lactic acid was 24. But I still put him on pump because he moved a little when they were doing CPR. There was enough blood getting to his brainstem and to his brain that he could wiggle. Nothing that was purposeful, not reaching for anything, but he could move, which told me blood was flowing. So put him on pump, and he left the hospital 3 weeks later. Every rule has been broken. But in general, these rules are still the rules we follow unless there's something else that tells us there's something different about this one, like they're moving a little bit with CPR. Once we have them on pump, then we can go ahead and do the coronary angiogram, the PCI. 85% of our people have significant coronary disease. Again, this is shockable patients, high degree of coronary disease causing that refractory arrest. We can fix that. We just need to bridge them to the fix, and that's what ECMO does for us. And then we admit them. They do have to achieve an organized rhythm before they get admitted. They have 90 minutes to do that once we finished all the PCI and everything else. So we have 90 minutes of medical therapy. Something you may all appreciate, the very last step of that medical therapy is a hot shot of potassium. We put them into asystole from their VF and then let them come back. And that usually gets them out. So we try everything that's standard medical therapy first. I would never suggest doing that for somebody who's not on ECMO or on pump for you guys. But for us, it's the last attempt. At that point, they would die otherwise. And it actually works pretty well. This is our data. The most recent time we looked at it a couple months ago, just about almost 500 patients. We're still right around 40% survival for patients who, again, an hour of CPR who would have been essentially left for dead by standard practices and now have a chance to live because of the hemodynamic support provided by ECMO. But it is a long haul, and that's the upper right graph. That's just the survivors. So these are all people with CPC 1 or 2, which is basically neurologically favorable survival. That's the cerebral performance category. It's a way of describing somebody's neurologic status after a cardiac arrest. 1 is completely normal, 2 is mild deficits you really won't even notice in talking to people. So each of those lines represents, again, only the survivors and the timeline of their recovery. So essentially all the patients are off the pump by a week, but then they're following commands later. They're leaving the ICU later and leaving the hospital around 2 or 3 weeks later. So these are, again, people in it for the long haul, and you have to wait the week and a half for them to actually start following commands and move around. And that's something that not a lot of critical care physicians will do either. So part of this, again, every link in the chain is to have the link of the ICU providers that are willing to wait on a person who's in a coma for a week and a half without telling the family that they're doomed to a poor outcome. You got to keep everybody hopeful but reasonable about how these people may do. And again, 40% of the people will leave the hospital doing well. The people who die tend to die of neurologic injury, as you may expect. 75% of them have severe neurologic injury. Half of those are catastrophic brain damage, herniation, and brain death. And that's shown in that graph on the lower right, where most of those people are dying early in the first 3 to 5 days. So many of the deaths actually happen, half the deaths or so in the first 4 or 5 days, and then the others may take a bit longer. So you can provide a little ongoing hope with just the fact that people made it through that phase as we're talking to families in the ICU. Now, that was all just a community protocol, something we just decided to do one day, and then educate the heck out of our community to get them to the point where we could do that. But we decided that we needed to describe to the world that it was actually useful, because as I went around, gave talks about this stuff for years, people would always say, well, you're cherry picking patients, you're finding the person who's basically playing chess with you, and you put them on ECMO and then they live. And that was not the case in our minds, but we needed to prove it. So we did a randomized trial, and this trial is called the ARREST trial. It randomized people, again, in our community, basically using that exact same protocol between the ECPR arm and standard ACLS. So half the people would get standard ACLS as provided. They would get it from the paramedics. They would transport people to the emergency department, or the emergency department physicians would do ACLS again and do anything they wanted to do, just not ECPR, and then declare them dead when they saw that it was futile. Or if they got ROSC, great, then we would do everything we could do to keep them alive. And what we saw was that basically the difference between the ECPR arm and the standard ACLS arm was drastic. We had 46% survival in the ECPR arm, and we had 6%, one person, survival in the standard ACLS arm. Now, keep in mind, these people are randomized after 45 minutes of CPR on average. So this is not the person on the street getting standard ACLS for the first 5 minutes. Those people still have a real good chance. By the time they got to us, they had almost 0% chance of surviving. And actually, that one person with standard ACLS who did survive to discharge died after 106 days because they left trached, pegged, in very rough shape. But to some extent, that tells you how hard we pushed to get everybody to live. Even in the standard ACLS group, we pushed for everybody. Once people discharge from the hospital after ECPR, they tend to do really well. You can see that blue line is just flat all the way out. People leaving after ECPR are leaving in good condition and living long, happy lives. Again, back to their families and their kids. So that's the data that the world had at that point, randomizing these people. Now, I mentioned this big difference. You'll notice there are only 30 patients in the study. We powered the study for 170 patients, but it was considered unethical after the first 30 patients to continue to randomize patients to standard ACLS. Now, if you remember what I just said, in 99% of this nation and in the world, people only have standard ACLS. So in our community, it is now unethical to do standard ACLS in perpetuity in this population, as deemed by this board. We had to stop our trial early because of that. So that's why we have a small number. So I think in our community, at least, we believe that ECMO now is an extra link in the chain of survival. It does not replace or eliminate any other links. Every other link is critically important. And I mentioned those cutoffs, the PaO2 and the lactic acid. If we don't have good work at each of the links preceding us, we don't get to ECMO because they're not in good shape to get to ECMO. So we really need everybody to be good for this. But what we still notice, even with that program, is that time was absolutely critical. For us to this day, if somebody has gotten to us within 30 minutes of onset of professional CPR, we have not had a death. Everybody that's gotten to us with 30 minutes or less of CPR has lived and left the hospital with ECPR. But every 10 minutes thereafter, we lose 25% of people. So mortality goes up quite quickly as time goes on. That's shown in the blue bars. That's still compared to the orange bars, which is the amiodarone arm of the ALPS trial. The ALPS trial was a randomized controlled trial comparing amiodarone to lidocaine and placebo in patients with shock refractory VF. One shock, then they got drug. We took the amiodarone arm of that trial to compare to our patients. So you can see that even at 30 minutes, it's drastically higher, obviously at 100%. After 40 minutes, the ALPS trial had no survivors, where we still have survivors, and it actually drops out about 15 to 20% survival, going out as late as 98 minutes is our latest survivor. But certainly you want to be on the quicker end of that time frame. So what we decided to do is take the ECMO to the patients to get closer to our patients so that we can decrease that time. And we did that at first by going to other emergency departments. So we were, again, used to doing it in the cath lab. We decided to make a mobile ECMO team that we would take to, again, closer to the patients by going to emergency departments that were spaced across the outer rim of the Twin City metro area. The University of Minnesota, for those of you who might not know the geography of the Twin Cities, because why would you? The University of Minnesota is pretty much in the middle, almost dead center in the middle. So we have our team there. That's where our ECPR program started. We have a second team that now drives out to these emergency departments to put them on ECMO. And the process is shown here. We have a central dispatcher through our flight medics and nurses who will call us when they get a call about a cardiac arrest. All of our EMS agencies, we have 7 of them in the Twin City metro area. They all will call that dispatcher with eligible patients with the same criteria I talked about. That dispatcher will coordinate which hospital they go to, one of our cannulation sites, and send our team there. We will meet them there. We will cannulate. We will take them to the cath lab at that hospital because they all have cath labs. And then we'll bring them back to the University of Minnesota for the post-arrest care. And as I mentioned, we're asking the paramedics now to be on scene for no more than 15 minutes for that entire extraction process. So they're thinking about leaving as soon as they know they have a shockable cardiac arrest patient. They're already planning their transport. They're continuing ongoing CPR, but they're planning their transport to get to us if they need to. This is us doing it in one of our emergency departments. The person sitting next to me is one of our flight medics who's cross-trained to do cannulation. The whole group will generally assist with the cannulation while the 2 of us cannulators will do the cannulation, one of us at any given time. But they will act as the ECMO specialist, the cannulation tech, and assistant. So a great team. We'll also have the emergency department team helping run the code and do other things for us at that same time. So now that blue circle in the middle sort of tells you roughly a 30-minute drive time around the University of Minnesota. The orange circles are now 30-minute drive times around each of these 3 hospitals, where each of the black arrows is now one of those cannulation sites. So you can see how we have expanded our reach now all the way to western Wisconsin from our little Twin City starting place. What you'll also see here, though, is that paramedics are infinitely optimistic about drive time. So we asked them to be within roughly a 30-minute drive time of our cannulation sites. There are those 4 dots up in the north, which are far outside the reach of anybody. And there's actually that one way in Wisconsin, the southeast corner there as well. So they will still come from far and wide. I think what that tells you is how much our paramedics have bought into the program, and also how much this gives them hope. And these are people that they would do the CPR, right? They would be the ones on scene. They would be the ones with crying family. They'd be the ones doing CPR for the 30 minutes and then sort of shrug their shoulders and say, there's nothing more we can do. And now they have something else they can do. And that's us. The big thing for us, though, is to get them thinking about it again in the first few minutes rather than waiting until the 30-minute window. And that's where the adjustment came in. Now, you will notice this is data from the first 4 months of our program right up to COVID. So we started the mobile program. We started the hospital-based program in 2015, but we started the mobile program in December 2019. And we had 4 months free of the idea that COVID ever existed, and had a huge increase in the patient population during that time because now we could reach so much further away. So many people from further away could come, and still maintaining about 40% survival. Our goal was to increase survival by getting to people faster. And we did get to some people faster, but we got to way more people. That was the effect. We just reached out, had a bigger catchment area now that we had these 3 extra cannulation sites. And so we had way more patients, but the average CPR time across the cohort is still about an hour because we just pull people from further away. So the next step was to take this truly mobile and to build a truck. And this truck is about a foot longer than a city bus. It is a cath lab on wheels, and it really brings, again, the cath lab to the patient. We now have this circle. You can drive 30 minutes. They drive 30 minutes. We meet in the middle, and we can really cover a huge swath of territory with this truck. This is the truck again next to an SUV that's all lit up with lights. Those SUVs are how we got with lights and sirens to the cannulation sites before. Now, instead of going to a hospital, we're rendezvousing with the truck. It is, again, a mobile cath lab. The basement or the floor of the truck is about shoulder height, has a lift to bring the patient up. You go up into the truck. We have a fluoro-compatible table, a C-arm, ultrasound, the whole basically mobile cath lab in that space with all the equipment we need to cannulate. The key thing for us is it's a controlled environment. We know where everything is. So just like the cath lab where we had the team that we knew, the supplies we knew, that's now just the truck. There are other ways of doing this out in the field. You could do it in parking lots and people's living rooms, but this truck is a controlled environment that allows us to do everything. So again, we've got 2 firefighters who drive the truck. You need a commercial driver's license to drive this truck. And it's because it's so big. So they drive, and then we have the rest of our team. Again, you can see there that we have ultrasound in the bottom left. You have the big monitor on the left where we can see everything. The C-arm, the ultrasound, all that is piped onto that screen. Theoretically, and our hope for the future is that we can use this for telemedicine. It has cameras and has the equipment to actually transmit all that data to VR-based modules that we have at the hospital, so we could be there running the code, helping assist with the cannulation process. We just haven't deployed that yet. This is what the big screen looks like. This was actually from our very first case, which you can tell because in the upper left is the back of a Zoll monitor that's supposed to be turned around to the camera, but the firefighters were excited to see what it showed. So they turned it toward them and away from the camera. But it's a learning process. We learn something from every single case. But you'll see in the top middle is the ultrasound. The top right is fluoroscopy. The bottom left is a camera. Again, for the telemedicine purposes, we find it very important to be able to see the groin, see what people would be doing with their hands. So we have a camera focused right there on the groin where the patient would be laying so that we can see them cannulating. The bottom middle is actually the patient's face. There's a large circle around it for privacy purposes, but they're bagging and we'd be able to see airway issues. And the bottom right is actually the CardioHelp screen with a little bit of drape over it. And so you can see we're getting access there to the femoral artery and vein, putting extra stiff wires up. We will use fluoroscopy to verify the position of those wires so that we know we've got one in the artery, one in the vein. This is all with ongoing CPR. So getting access in these vessels seems like it should be an easy task, but it really isn't with ongoing CPR. Then we will dilate those up. We'll put the cannulas in and get going. The cannulas, I know you're familiar with these sorts of cannulas, but they are just large spears. And so especially the venous cannula, the 25 French venous cannula, we position up from the groin, across the right atrium into the SVC, and we use fluoroscopy for that, just for safety. So another reason that it's really helpful here, you can see that venous cannula going in. Another reason it's very helpful to have that C-arm in the back of this vehicle so you can safely place this cannula in the optimal position. If you didn't have this, sure, you could settle for a less optimal position, stabilize them, and then get them to the hospital. But in this way, we can provide them great flow, that 4.5 to 5 liters of flow right from the beginning. So not to belabor this too much here. So there are other ways to do mobile ECMO as well. So again, the truck is our way in Minneapolis, Minnesota. The folks in the Netherlands have a helicopter-based crew they're rolling out, and they don't have any results from that yet, but eager to see how that goes. The folks in Paris have been doing it on a tarp in the sidewalk for a while. They have a lot of difficulty getting patients to the hospital in time. They have really narrow streets, difficult traffic. So they brought the ECMO to them, to the patient a while ago. They have dramatic pictures of them putting people on ECMO in the Louvre and in the subway here. Their results, they are better than they would be without the ECMO for sure. But they have a hard time getting this done in the field, and it's completely understandable. Again, the fixed environment of the truck is critical for us. So in summary, ECMO has become a critical link in the chain of survival for patients with refractory cardiac arrest. And again, we've shown primarily shockable patients, but these other sites have done it in non-shockable patients as well. The shockable patients, not surprisingly, do better, but still it could be applied to everybody. ECPR is a system of care though, and you need to strengthen every link in the chain of survival and also really focus on the entire aspect of the procedure and the process. A multi-system organ failure is ubiquitous in these people. You need great critical care and 24/7 multidisciplinary care to help them recover from all their injuries. And that recovery is long, but entirely doable. And you can have a lot better survival with this sort of system compared to what we had before. So thank you all for your attention. I'm certainly happy to answer any questions.